Good morning, everybody. Very good to see you here today. My name's Graham Hart. I'm Professor of Sexual Health and HIV Research here at UCL and also Director of UCL Health of the Public. And a very warm welcome to you all in the room and online to UCL Health of the Public's 4th Annual Symposium, which today is about shaping health from the early years to older age. It's great to see so many people in the room and, as I've said, so many online as well. And we've got a full programme today of opportunities to hear about research from not only UCL researchers, but also colleagues who come from the University of Glasgow, Age UK, and the London Borough of Newham. We're not expecting any fire alarms today, but if you do hear an alarm, please leave by the exits signposted. So we've been going UCL Health the Public for about 4 or 5 years now, and our initiation was very much as a result of the Academy of Medical Sciences report improving the health of the public by 2040. And this was a powerful argument for engaging a range of disciplines beyond the usual biomedical disciplines in health. And that's what we've been pursuing ever since. We achieve this through strengthening research communities across UCL and increasingly externally, supporting the development of new and innovative collaborations, particularly for major strategic funding applications. And in the 4 or 5 years that we've been going, we've helped generate for UCL nearly £80 million worth of research grant funding and fellowships. Really, we want to continue that good work, and you'll be hearing some of that today. We're supporting a range of communities across UCL on health equity, climate change and health, urban health, and creative health, as well as our early career network. And you'll be hearing from some of our ECRs during the course of the day. We're a first point of contact for local authorities, the NHS, third sector businesses, and other research organisations in the health space when that is oriented towards improved population health. For those of you online, we'd encourage you to submit any questions you have for our speakers and panellists via the Slido link, which is there, and in your joining email. We're very fortunate today to have Professor Mark Steers, Director of the UCL Policy Lab and Pro-Provost Policy Engagement. And Mark is going to say a few words as we begin. Thank you, Mark.
Good morning, everyone. So wonderful to be here, and thank you so much to Graham for the invitation to say a few remarks at the opening of your extremely exciting day. I'm not going to take an awful lot of time, but I do want to say about why UCL Health of the Public matters so much to UCL. And why it is so integral to the mission that I think we have as an institution and as an institution situated in deep relationship with many other partner organisations who I know are also represented here today. You all know, I'm sure you've heard it many times, but you all know that UCL is almost 200 years old and that since the beginning of the institution, it has been dedicated to doing things differently, to disrupting conventional wisdom, to be opening up new opportunities, to be challenging orthodoxies where they exclude people who should not be excluded. And I think that the mission that you have here today really reflects the core components of that institutional identity. And I just want to share 3 thoughts that I hope you might be able to hold with you as you go through your discussions today. I mean, the first, obviously, and you're going to hear masses of this today, is about academic excellence and is about breaking down barriers of new ideas and new thoughts, of sharing the fruits of your scholarly wisdom. And the institution, of course, prides itself very much on its ability to be at the cutting edge of new intellectual developments. And so we are an institution of academic excellence, and we make no bones about that, and we are tremendously excited to be able to support research at the cutting edge. But there are two other things that UCL has, which I think some other institutions perhaps don't have as much, which combine with that academic commitment. The second is a deep belief in the power of collaboration and breaking down the boundaries between different disciplines, different sub-disciplines, but also between scholarly endeavour and non-scholarly endeavour. I mean, UCL has always had this deep belief that each of us only has a fraction of the answer to the problems that we are confronting. And what we need to do is to find the other people. It's like a kid's computer game. There are other people in the room who have the other fraction of the answer. And our job is to find those people and establish trusting relationships with them so that collectively our ideas will add up to something much more profound and much more capable of rising to the challenges that we face ourselves with. So today is a sort of instantiation of that there is in the room so many different kinds of expertise, and I'm hoping that you will find that in the panel discussions, in the breakout discussions, and that you'll carry on those collaborations through and co-create answers together in the knowledge that, brilliant though each of you are, your expertise is partial without finding other people who can bring their expertise to bear too. And the third part, so if the first part is excellence and the second part is collaboration, the third part of our sort of institutional mission is probably obvious to you, but is not obvious always, is that what we do matters. You're going to be talking today about the early years and about the later years of human life. You're also going to be talking about the fundamental elements of people's ability to thrive. I've got a 9-year-old daughter who goes to a primary school, a wonderful primary school in Hackney in East London. And as she gets older, every day, it's extraordinary. Every day she comes back with more stories, more anxieties about the injustices, unfairnesses, difficulties that are faced by her peers, by their families, their older relatives, by the communities in which they live. People who don't have adequate housing, people who are faced with chronic health issues, people who can't get to see their GP on time, people who have social care relationships which are not everything they ought to be. And she, as a 9-year-old, brings these things back to me every day. And I'm thinking, that is a small instantiation of what is happening, of course, across our city, across our country, and across the world. Intense social challenges experienced by both those towards the beginning of their life and towards those towards the end of their life. Your work is a reassurance to my daughter. Because what I said to her this morning is that, of course, these are incredibly difficult challenges that you and your peers are facing. But there are people in places like UCL, in gatherings like this, who are bringing their wisdom to bear on them, building new relationships with others, and hopefully will make an incremental improvement to the world that we see. And so that's what, to me, UCL is all about. Excellence, collaboration, and contributions to the common good and defeating of deep social injustice. So it's a huge privilege to be able to open this debate and discussion. I hope it goes extraordinarily well, and I look forward to being able, from the institutional perspective, to support the endeavours long into the future. And with that, I'll hand over to Pia, who's going to do our first session. Thank you very much.
Great, thank you so much. I'm Pia Hardelid. I'm Professor of Epidemiology here at Institute of Child Health, and I am absolutely delighted to see so many people here at our institute, but also to chair this session on building a strong foundation health in the early years. So we know that the early years of a child's life are absolutely critical for their health and well-being throughout childhood, into adulthood, and then into later life. But an Academy of Medical Sciences report from just last year shows that children's health and well-being in the UK is very concerningly actually worsening. And it's therefore more important than ever that we address factors such as poverty, racism, ableism, maternal and paternal health, and early education to ensure that children have the best start in life. Now, we also know that children who grow up in poverty are more likely to experience poor nutrition, unstable, unsafe housing, limited access to early education and later education, and also they're more likely to experience exposures to environmental pollutants. And these early disadvantages, they don't just affect children's immediate well-being while they're children, which is of course really important in itself, but these disadvantages persevere and accumulate across the life course to shape the health of the public for decades to come. So really early intervention to support children and their families is absolutely key. But over the last 30 years, children and families with children have consistently been the poorest groups in UK society. Now, retired people, on the other hand, they used to be the second poorest group about 30 years ago, but now they are by far the wealthiest. And that just shows you that the government, if they want to, really can reduce entrenched poverty and inequality. So we are at Institute of Child Health today, and UCL has a long-standing commitment to improve child health, drawing on world-leading expertise across disciplines including epidemiology and public health, clinical pediatrics, psychology, education, economics, law and beyond. And that reflects really, I think, the complex and interconnected factors that shape children's health and well-being. So in this session, we will hear from experts in some of these disciplines, both from within and outside UCL, and they will highlight some of the exceptional research being conducted to understand the determinants of child health and health in the early years, and also to develop evidence-based interventions that can truly make a difference to children and their families. So thank you again so much for joining us today. So we'll start with our first presentation. And I'm absolutely delighted to be able to introduce Professor Helen Minnis, who is Professor of Child and Adolescent Psychiatry at the University of Glasgow. Thank you so much, Helen.
Thank you, Pia. Thank you so much. I'm really honoured to kick off this day, and obviously starting with the very youngest children. I'm going to focus right down today on two things that are hugely important in the media at the moment: neurodivergence and trauma in early life, because I think this is where there is really a chance for prevention. So you probably all know about the decades of work that's been conducted on adverse childhood experiences. So this is a very famous slide from Felitti and Co. It's now about 25 years old, demonstrating the adverse childhood experiences. So on the left of the slide, you've got abuse and neglect, which we're all very aware of. And on the right of the slide, you've got household dysfunction, which is things like growing up with a parent who's incarcerated, a parent with a severe mental illness, but then also common things like divorce. And there's been a lot of research looking at the cumulative impact of adversities, even very common ones that probably on their own are not a major deal. But dose-response relationships like these are very famous. This is old news. We've known this since the 1970s, that if you have cumulative childhood adversity, you're at much higher risk of experiencing depression in later life. But this was big news, the second dose-response relationship, which shows that if you have 7 or 8 of these adversities in childhood, you're at more than 3 times the risk of developing heart disease in later life. So this really woke up the medical and scientific community when these findings came out. And at a population level, the bigger the load the child is carrying, the bigger the risk of poor health outcomes. My clinical work as a child and adolescent psychiatrist and my research has always focused on what we call maltreatment-associated psychiatric problems. So the kind of mental health problems that arise in some children and young people who have experienced abuse and neglect. And we noticed back in 2013 that people who had been maltreated and who had psychiatric problems tended to have particularly complex, overlapping problems and a lot of impairment. But that's where the really interesting conundrum arises, because actually many people who've been abused and neglected don't have any psychiatric problems. It's really easy to forget this as a psychiatrist. So we need to remember that good health is also a completely positive and fairly common outcome of being abused and neglected. So there's something funny going on here. So the bigger the load, the bigger the risk. But we have to remember that not all people with a big ACE load do develop problems. So what else is going on? And obviously for a public health audience, you're already starting to think, well, if some people have a problem and some don't, then surely there must be opportunities for change. We noticed that the complex overlapping problems were often neurodevelopmental, so included things like ADHD, autism, intellectual disabilities. And I wondered whether this was just a referral bias, whether people were sending me the most complex patients. So we decided to look at this in a really large population study, the Child and Adolescent Twin Study in Sweden, CATS. We focused on children at the age of 9. And when I say we asked, actually they had already asked using a well-validated screening that's been validated against diagnosis for ADHD, some traits of ADHD, autism, tic disorders and learning disabilities. And the fundamental question, and actually for me initially the only question was, are abused and neglected children at the age of 9 more likely to have multiple neurodevelopmental conditions? I was just interested in confirming or refuting my clinical impression. And the answer was yes. But it was an even bigger yes than I had expected. So there was a fairly small, a few hundred children in that population that had traits in 3 out of the 4 of those areas that we looked at, and they were nearly 10 times as likely to have experienced maltreatment. So it wasn't just a clinical impression. But this was a twin study, so we were able to look at causality. So we then went on to ask the question, does abuse and neglect cause this increased neurodevelopmental load? And the answer was a resounding no. So children who'd been maltreated, yes, they sometimes, if they had these traits, might have an increased symptom load, but our findings demonstrated that actually additional genetic factors were causing both the abuse and neglect and the child maltreatment. And I remember when we got these findings, I noticed, we were on Skype back then, that my colleague, my clinical psychologist colleague, her mouth was an O shape. And then I realised that so was mine. We were both like this. Because this was exactly the opposite of what we'd expected to find. I'd always assumed that abuse and neglect caused this complexity. So we started to wonder, could these be neurodevelopmental conditions running in the family? And I would say this is still an open question. No one has been able to completely confirm or refute this. But it has really started us wondering, and many other people wondering, could neurodevelopmental conditions in the family increase the risk of abuse and neglect? And actually, we've known for decades that childhood disabilities do increase the risk of abuse and neglect. I mean, that was actually old news, but it just, I don't think, had occurred to us that this could also be the case for ADHD and autism as well, and tic disorders. And I guess it just caused us to remember that parents may also have heritable problems with things like learning, impulse control, language, or social understanding. And I just want to pause for a very quick caveat to say that actually, there is some evidence that neurodivergent parents can be better parents of neurodivergent children because they kind of get each other. But then you throw in the environmental factors of poverty, racism, various other stigmas that maybe create barriers to service access, lead to late diagnosis. There's evidence that children who've experienced ACEs are likely to be misdiagnosed or have a later diagnosis of a neurodevelopmental condition. And then you can start to see vicious cycles emerging. Yes, I've just said all of that. So with my colleague Ruchika Durrani, who I just mentioned, we came up with the double jeopardy model, as we've called it. And we examined this once again back in the cat study, although this time we didn't use it as a twin study, we just used it as a big population study, to ask the question whether there could be what was the impact of having both a history of maltreatment, abuse and neglect, and being neurodivergent. And what we found, we focused on mania symptoms at the age of 15, because that's a kind of adult type symptom that you tend to only see after adolescence. And what we found was that 9-year-old twins who had both been abused and neglected and had and were neurodivergent were at twice the risk of developing mania at the age of 15. And we've actually got some other evidence, none of it published yet, but also for physical health problems that seem to support this double jeopardy model. But there's a lot of scepticism out there in the media, social media, and these are just some of the headlines. You know, is there overdiagnosis? You know, what do we do about this? And there is a huge service pressure. And this is a quote from the wonderful, absolutely wonderful, compulsive, recently published autobiography by Fern Brady, the internationally famous comedian, who was diagnosed as autistic at the age of, I think, 34. She says, for most autistics existing in a world not built for them, anxiety is the baseline and constant background hum that their daily life has to play over. So is there overdiagnosis? Well, perhaps in some areas, in some ways. We should be reassuring to the public that autism and ADHD are differences, not disorders. Some people with ADHD and autism traits are doing absolutely fine and don't need mental health services. But we also need to identify those children, adolescents and adults who are suffering so that we can modify the environment and support their families. And I think that this would reduce daily anxiety, probably would reduce the likelihood of the onset of severe mental illness. It would reduce family stress. It would support parents. I think it would reduce the prevalence of child abuse and neglect. Wouldn't that be a great outcome? It would improve the health of the population. So I'm not sure if there's time for questions now or at the end. Well, hold on to your thoughts.
Great, thank you so much, Helen. That was absolutely fascinating. So so there will be questions at the end, and we'll have a Q&A here with everyone who's been speaking. So now I have the absolute pleasure in welcoming my colleague, Professor Katie Harron, who's a Professor of Statistics and Health Data Science here at Institute of Child Health.
Thank you very much, Pia. Okay, so I'm going to talk about how we can use linked data, longitudinal data from health, education and children's social care to support research to transform child health in England. And a lot of what I plan to say actually chimes with Helen's talk, so it's really good to hear that. So Pia's already mentioned the Academy of Medical Sciences report that was published last year, which really showed this appalling decline in child health over the past decade. And the statistics really are shocking. So by the end of primary school, 1 in 5 children in the UK are overweight or obese. 1 in 4 had tooth decay. There's been a huge surge in demand for mental health services, and infant mortality, shockingly, was ranked 30 out of 49 in 49 OECD countries. And all of this has coincided with the number of children living in extreme poverty having tripled since 2019. If we want to build a better future and promote the nation's long life health and well-being, then intervening in the early years is absolutely critical, because this is when we lay down the foundations for long-term mental and physical health. And to do this, we need, obviously, high quality health data. But as the UCL Health, the public strapline says, health beyond disciplinary borders, we need to think beyond our disciplinary borders to think about how different parts of our life are related to health, how health is related to the households that we live in, the schools that our children go to, and the wider environments in which we live. We know, for example, that health and education are inextricably linked. This was a study that we did looking at the association between gestational age at birth and school attainment at ages 7 and 11, Key Stage 1, Key Stage 2. And because we had whole population linked data, we were able to look at the impact that each week of gestation had for children with specific chronic conditions. And this is a huge sort of step forward over previous studies that have had smaller sample sizes that have had to group together all preterm pregnancies. So because we had this large data set, we were able to show that even being born just a couple of weeks too early can have a lasting impact on children's ability to learn all the way up until the end of primary school and beyond. So by sharing information across services like this, we can help inform parents, clinicians, educational professionals about the likely outcomes for different groups of children, to inform decisions about clinical and developmental follow-up, and to ensure that the right support is in place to enable all children to be prepared to start school. The pathways between health and education might be quite clear, but we also know that the reverse can happen too. So our educational experiences can impact on our health. This is a study led by Ruth Blackburn here at ICH, which shows the rate of stress-related presentations in hospital admissions according to school or term time. And you can see a clear pattern here across all the secondary school ages, whereby these stress-related admissions were much higher during term time and then were reduced during the school holidays. These are admissions that are related to early mental health concerns, and include things like self-harm and pain, and they're actually really common, affecting 2 girls and 1 boy in every classroom. But if we're able to use these early indicators, then we have an opportunity to tackle these early signs of mental health concerns, and through appropriate and effective interventions, ultimately reduce the likelihood that these conditions will develop clinically later in life. So these types of studies have been made possible through linkage of routinely collected data from health, education, children's social care services. We've developed a data set called eChild, which links together information from the Department for Education on school attendance, absences, special educational needs, also children's social care data, with hospital data from NHS England. Because we've got data on the whole population, the data set includes 20 million children, so it's absolutely huge. And for the oldest members of the cohort who were born in 1984, we can follow them up from birth all the way up to age 38. We link together additional data sets, so maternities, births, mental health services, and community services data, which includes health visiting for the under 5s. So it's a data set that really sits between this health and non-health divide, and is a step forward from working in data silos. By linking these longitudinal data across the life course, we can start to put together the different pieces of the picture of how children interact with services through the life course. And this is important because children tell us there's a lot of frustration from families about having to repeat their stories to different services. So having a more joined up view of things is really beneficial. One of the other aspects of eChild that's really unique is the fact that we can link mothers and babies together, and this sort of chimes a lot, I think, with what Helen was saying. So we can understand what happens in the mother's life prior to or during pregnancy that might impact on the child, on the first child, on the second child. How do siblings interact with each other? So this means we can look at the influence of maternity and pregnancy factors on child outcomes. We can think about that intergenerational transmission of adversity, how different health, physical and mental health conditions might cluster within families, the effects of health conditions not just on the sibling who has that condition, but also what happens to the other siblings in the family. How is their school attendance affected, for example? And because we're able to identify siblings within the data, we have the potential to do the types of studies that can tease out those effects of genetic and environmental exposures. Some recent work done by Steffi in our group here at ICH has looked at child health and educational outcomes for mothers who have been involved with children's social care services as an adolescent. So we looked at 200,000 mothers who gave birth between 2012 and 2020, about a quarter of whom had children's social care involvement between the ages of 11 and 16. And you can see that after controlling for a range of maternal characteristics, children born to mothers with that social care history had much higher mortality rates and were more likely to be born at low birth weight. And we can also look at educational outcomes in these children. So we looked at the early years foundation stage profile, which is a measure of school readiness at age 5. So this data is starting to show us that although these children are accessing, or these mothers are accessing support through social care services as adolescents, there's a need to understand the best ways to continue to support these families after that children's social care involvement has finished. Steffi's got a poster on this if you want to go and find her at lunchtime. So the Academy of Medical Sciences report recommended that in order to reverse this decline in child health, we need to implement effective early years interventions and address the decline in child and family health workforce. So health visiting is a key early years intervention. Health visitors are trained nurses and they're uniquely placed to address a range of health and social needs in children and families. They should be seeing all children under the age of 5. But due to years of austerity, cuts and a depleted workforce, health visiting teams have decreased by 37% since 2015. And work done by Louise McGraw-Lone, who's here somewhere, has shown that the real-term value of the overall public health grant from which health visiting is commissioned has decreased during this time by 15%. But actually for the 0 to 5-year-olds, the youngest in our population, it's decreased by 37%. So we're really disproportionately affecting, these cuts are really disproportionately affecting the children in our population. So in the context of that disinvestment, local authorities are having to make decisions about how they deliver services. This work, led by Mung-Win Liu, has shown that the percentage of families receiving their 2 to 2.5 year review, which is a mandated review that all children should be having, ranges from 33 to 97%, depending on which area children live. Despite these pressures on services, we have shown that almost all children are seeing the health visiting teams within the first year of life, and actually it's a significant infrastructure. Some children are receiving really intensive support. 1 in 4 children have 3 or more contacts over and above the mandated contacts in the first year of life, and a small proportion, 1 in 25, have 10 or more contacts. It's a significant infrastructure that we can build on to try and improve child health. But it's actually quite difficult to evaluate these types of universal services within routinely collected data. One of the reasons being that we don't always capture the most relevant or meaningful outcomes, such as maternal well-being or parent-child interaction. So these studies are actually part of mixed methods studies, and qualitative work led by Jenny Woodman at IOE has shown that the huge impact that health visiting can have on children and families. And I want to leave this here for a minute because I think it's important. We talk about data a lot, but to understand that there are stories behind the data and individuals with individual stories. This mother here is talking about the fact that the health visitor came and stepped in and prevented her from maybe losing her baby or worse, and talking about this intergenerational transmission again of how she was brought up as a child and what she now understands is perhaps a better way of doing things. Okay, then to summarise, investment in universal and targeted interventions in the early years is really critical to be able to promote the health of the future adults in our population, and there's clear evidence to show how cost-effective implementing these early interventions will be in terms of acting early to prevent future burden. Through linked data, we can do better with joined-up thinking and think about descriptive work, which describes long-term outcomes for children with specific health conditions to inform clinical developmental follow-up. To understand how services overlap to support children, where there is variation that might be unwarranted, and who is falling through the cracks. exploring the contribution of the wider family context. I've talked about the mother here, but we can think about the household. And we could do even, so much more if we were able to link to employment and benefits data and more granular information on household income, as Pia said, so important. And then finally, underpinning interventions and policies with high quality research and evaluation done carefully with robust methods and recognising where we can learn from a range of different study types, including qualitative and survey work. Thank you very much.
Great, thank you so much, Katie. Brilliant presentation. So now we move on. I'm delighted to be able to present Dr. Rosa Mendizabal, who's a lecturer at the UCL Institute of Education. So Katie's mentioned education, so that's a really nice move over. Thank you.
Well, good morning and thank you everyone for listening to this presentation. My co-authors, Dr. Kelly Dixon, Professor Ling An, and I would like to thank you for the opportunity to present our work here. I will be sharing findings from a qualitative evidence synthesis conducted at the UCL Epicenter in Institute of Education in collaboration with the International Public Policy Observatory and the Wales Centre for Public Policy. Our study set out to explore access to early childhood education and care among ethnic minority and disadvantaged families, focusing on 3 key research questions. Today, I'll focus on the second research question, which is, what are the barriers and enablers to participation in early childhood education and care amongst these families? Access to early childhood education and care is widely recognized as a critical determinant of child development and a tool for reducing inequality. It contributes not only to children's cognitive, social, and emotional development, but also to family well-being, parental employment, and school readiness. While much attention has been paid to quality and outcomes, fewer studies have focused on how families actually access these services and what barriers and facilitators shape that process, particularly for families from ethnic minority and disadvantaged backgrounds. So to guide our review, we adapted a framework originally developed to understand access to healthcare. This model accounts for both the supply side and the demand side factors, from policy design and service delivery to how families perceive, engage with, and act upon those services. This dual lens helped us examine system-level conditions like funding, availability, and outreach, as well as individual responses, including trust, language barriers, or logistical concerns. In short, it allowed us to better understand not just what the barriers are, but why they persist. Our study was rooted in the needs identified by the Welsh Government Anti-Racist Wales Action Plan, which names early childhood education and care as a critical area for promoting equity and inclusion. Our engagement with policymakers and community partners helped shape both the scope and the relevance of our review. Given the limited evidence on ethnic minority groups alone, we broadened the lens to include disadvantaged families more broadly, defined by social, economic, or health disparities, while remaining attentive to how intersecting identities shape lived experiences of access. This is just to show the breadth of the study, and I will be talking about the 42 studies that we identified to answer research question number 2, which were of relatively high or moderate quality. we conducted a framework synthesis using qualitative studies from the UK and comparable contexts. Our process prioritized participant quotes, authors' interpretations, and patterns in access, uptake, and users' experience. For the purpose of this review, early childhood education and care refers to the provision of care and education for children from birth to the start of primary school. It encompasses a wide range of formal and informal services, including childcare, preschool education, and other forms of early learning. The focus is on supporting children's development in cognitive, social, emotional, and physical domains during their early years. So we take it as the comprehensive approach that includes the care, education, and development of children from, and also refers to the importance of providing nurturing environments that support children's learning and well-being from infancy through their preschool years. Access to early child education and care refers to enhancing participation rates and meaningful engagement with the early childhood education and care. And it could include strategies and mechanisms to increase access alongside an understanding of the barriers and enablers to contributing to increasing the involvement and encouraging more families to enroll their children in formal childcare. By using the Archambault framework, we organized barriers in relation to broader structural forces and lived realities. So I'm going to be presenting findings from the demand side, which is split into the perception or the awareness of families about the childcare provision, how they seek to access these services, the active reaching, which includes the individual barriers, support and facilitation, service provision and expectations, the active access to the services, including resource variation and service accessibility, affordability, and the active engagement with the service, which talks about the relationship with an engagement of the services. Regarding active perception, in the UK, we found that while general awareness of free early education and entitlement is relatively widespread, there are notable gaps in understanding among ethnic minority and disadvantaged families about how to access these services, and misconceptions about who qualifies and confusion over the types of support available. Well, we think misconceptions about who qualifies and the confusion over the types of support available can discourage the uptake of these services, even when families would otherwise benefit from engaging with them. Informal networks, such as friends, neighbors, or community leaders, play a vital role in disseminating information, especially in disadvantaged communities. However, these networks don't reach everyone. Families who are more isolated, newly arrived, as in immigrant, asylum seeker families, or less well-connected are often left behind, particularly in the absence of centralized and regionally coordinated information systems. Despite these access barriers, parents consistently recognize the value of early childhood education and care. They describe its role in preparing children socially and academically, while also providing them as parents with respite and new opportunities. However, some parents were also hesitant to use childcare services due to concerns about the quality. These concerns include underqualified staff, unwelcoming or poorly equipped settings, and a perceived lack of individual attention, particularly for younger children. These quality concerns intersect with social and cultural expectations. For example, extended families may view childcare as a private family matter, which can discourage women from enrolling their children in formal settings. Language is a critical barrier, particularly for migrant and refugee families. Parents worry that their children may fall behind because of limited exposure to the majority language. And interactions with staff can be strained when communication is difficult. This often leads to a preference for home-based or kinship care, which, while culturally familiar, may not always meet children's developmental needs. We also found that immigration and employment status directly limit access. Families facing insecure work or ineligibility for subsidies, especially mothers who are unemployed or precariously employed, struggle to secure consistent childcare places, even when demand is high. In response, many families rely on flexible care from relatives, especially grandparents. Finally, one of the most consistent findings was the importance of trusting, respectful relationships between families and early childhood education care providers. When families feel seen, supported, and heard, especially through strengths-based approaches, they are far more likely to engage with the services. But when trust is broken, whether through mishandled information or negative past experiences, the damage can be lasting and families may withdraw. Overall, the suitability and responsiveness of the services across timing, structure, cultural relevance, and communication emerge as key drivers for engagement. In terms of health implications, well, we think that they are significant. First, early childhood education and care is often a gateway to health services, like screening, vaccinations, and early interventions. When access is compromised, these health benefits might be lost, reinforcing early health inequalities. Second, childcare access supports maternal mental health, offering respite and enabling employment. Inaccessible systems can heighten stress, anxiety, and social isolation. Third, language and cultural barriers reinforce structural disadvantages. Families who aren't well connected or fluent in English are more likely to miss out entirely on services that support their children's development and family well-being. So we came up with a few policy and practice recommendations, but I want to highlight these 5. To improve access and address these inequities, we propose that policy would benefit from integrating early childhood and education and care information into health settings, like GP surgeries, health visitor appointments, or maternity services, training healthcare and social workers as trusted intermediaries to share accurate information on childcare entitlements, simplifying communication using plain language, visuals, and multilingual resources to improve health and early childhood education and care, recruiting and retain bilingual staff in early childhood education and care settings to reduce language-related barriers and foster inclusive environments, and enhancing quality and cultural responsiveness of these services to build parents' trust and support children's holistic well-being. Thank you very much.
Oh, thank you so much. That was absolutely fascinating. So now, last but absolutely not least, I have the pleasure of introducing Nora Trompeter, who is a postdoctoral research fellow also here at the Institute of Child Health.
Great. Thank you so much. So today I want to share with you some findings that we've been looking at the Edify cohort, where we're study where we're looking at the specific topic of childhood food insecurity and how that might link to adolescent eating disorders. So a little bit of background, but I think my other speakers have set up the background really nicely, is that we know social determinants of health are increasing. In particular, food insecurity is rising globally, including in the UK. It's estimated that around 15% of UK households experience food insecurity more recently, and more concerningly is that the households with young children are even more at risk of experiencing food insecurity. And as I said, food insecurity is a known social determinant of health for both physical and mental health disorders, and for the point of my talk today, it includes eating disorders. And the reason why that might be, or some kind of suggestion, is that it leads to a kind of circle of fast and famine. So you might start, often you are experiencing food insecurity, have more of a famine period where you have limited access to food and you're relying on very limited food to get you through the day. You might then start to obtain more food, you might have more money coming in or some other type of support, you recover a bit, and then you might find yourself for at least a short period of time being food secure, where you have access to food, and because you might not know how long that access to food lasts, and because you have been restricting your food intake, it might lead to a feast period, and then kind of the food declines, you might not have the resources to obtain more food, and it cycles back into a famine period. And when speaking to people with lived experience of both food insecurity and eating disorders, they describe how these kind of periods impacted their eating behaviours and the relationship they have with food. So in the famine period, both leading to restrictive behaviours, but also that anxiety and distress they feel during that time. And often experiencing episodes of binge eating during feast periods that really contributes to their eating pathology. But before I go into it a little bit further, I do want to just briefly touch on why we're talking about eating disorders at a public health forum, because it might be something that we think of it as more niche psychiatric disorders. But I really want to highlight that eating disorders are unfortunately much more common than we think. The prevalence rates are rising, especially in young people, and they have really high social and economic costs that, especially if we intervene early, we can all reduce. So, just briefly, as I said, eating disorders are unfortunately much more common than we think. At any point in time, it's estimated that over 1 million people in the UK are affected by eating disorders, with a disproportionate number of young people. So this is a report recently published by the UK Parliament, where the 17 to 19-year-olds, you might see about 12.5% of them are estimated to have an eating disorder. And these are just when we're talking about clinical disorders, but even at the subclinical level, where we have symptoms of disordered eating or thoughts and cognitions aligning with that, it's a much higher rate. And concerningly, these rates are rising. So this is recent data from hospital admissions for eating disorders compared to other mental health disorders. And you might not be able to see very well, but the yellow line in the graphs is the rise of eating disorder admissions, and the other colours there are some other mental health disorders like anxiety, depression, substance use. So you can see there are increases in general in mental health admissions, but particularly concerning for eating disorders. And they are very costly. They have a high cost of treatment, long-term care, and also disrupt education and employment at a really critical time to young people, which results not only in annual loss to the economy, but also healthcare costs. So, intervening early is critical. So, back to the topic on food insecurity. So we know fairly little about the links between food insecurity and eating disorders, especially from a childhood perspective. Most of what we know focuses on adults, and it's mostly captured as a moment in time. So asking people whether they're experiencing food insecurity and then linking that back to how their eating is. But we know that food insecurity often, if someone experiences in adulthood, maybe they have a history of it during childhood, and it's also not something that's necessarily stable. So someone might start out being food secure and then become food insecure, and vice versa. So we really wanted to look at this period of childhood and also look at it as a kind of trajectory. To do this, we used data from the Outback study. So that's a birth cohort study from the area around Bristol. We had just under 7,000 participants in our study, and they provide. We had data on food insecurity as reported by the mothers, and then we had information about disordered eating as reported by the adolescents themselves. And for all the results I'm going to present, this is controlling for parental education, parental mental health, child sex, child BMI. And we found, when we're looking just at the child food insecurity, that there are really 4 distinct groups of children that we can group them into. So happily, the biggest group was the no food insecurity group. So these are children who never throughout their childhood experienced food insecurity. Then we had a smaller group of those who experienced low levels of food insecurity. You can see them as the blue line on the graph. Then we have the group that we're calling the time-limited food insecurity. So these are the green line. And this is a really interesting group because you can see from the ages from 0 to 5, they really ranking higher in food insecurity, but then at age 5 they drop. So these are the children who probably experienced food insecurity prior to starting school. And then we have the persistent food insecurity group in the yellow who throughout their childhood experienced food insecurity. Right. I'm not going to spend too much time on these graphs and numbers, but for those who are interested, they're there for you to have a look at. So we then looked at comparing the groups. So we always compared to the no food insecurity group and wanted to see, does belonging to any of the other food insecurity groups, is that associated with a higher likelihood of experiencing either binge eating or compensatory behaviors? So that might be something like fasting. And we saw that the children who were in the time-limited food insecurity group had a higher likelihood of binge eating at age 14. Those in the persistent food insecurity group had a higher likelihood of engaging in compensatory behaviors. This is the age 16 data. We didn't find any significant differences there, but I would like to note and highlight that because this is a birth cohort study, we do have a drop in participation and reduction of statistical power. And then lastly, we have age 18. So here, the time-limited food insecurity group had a higher likelihood of engaging in compensatory behaviors. So just in case you missed that, so here's just a little summary, but kind of mainly to summarize, it's that belonging to either the time-limited or the persistent food insecurity was associated with higher odds of engaging in both binge eating and compensatory behaviors in adolescents. And I think it's really interesting that it's those 2 groups where we're seeing those associations, and in particular for the time-limited group, that even those who did obtain food insecurity still have similar patterns to those who were persistently food insecure. So that really points towards maybe potentially intervening early. Obviously, food insecurity is not something anyone should experience at any point in their lifetime, but it might be something that's particularly vulnerable about experiencing it in early childhood when we're thinking about disordered eating. We also need to understand more about what it is that links these 2 problems. So what is it about the food insecurity that makes people more vulnerable, and how can we help those people? And just lastly, pointing out that whilst this data is really informative, in which we are talking about food insecurity as experienced by children in the 1990s in a very specific geographical area. So it'd be really great to see more recent data, but which is always hard if you're looking at long-term outcomes, because obviously you'll have to wait until those kids grow up. But yes, that is it for me. If you are interested in the topic, our Edify research team has created an animation on the topic of food insecurity and eating disorders, which you can check out with the QR code if you like.
Great, thank you so much. So please stay, because now we're going to have a question and answer session. Can I invite all the speakers, please, to come and sit on the stage? And then we have about, I think we have to speak into the mic when you answer, just to be clear on that. because of the people online. And we're going to please do submit questions via Slido. And then we have roving mics here, and then we'll kind of switch in between those. But I've got loads of questions, but I've talked too much already. So are there any questions for any of our speakers or for all of them? Oh, yes, thank you.
Hello, my name is Sudakshina Murdan, and I'm at the UCL School of Pharmacy. I'm interested in vaccine hesitancy, and my question is about the eChild database. Could the data be used about, for example, maternal vaccination and uptake of childhood vaccination, be used to find things like to correlate with attainment at school? And I wonder whether that might be a good motivation to, when trying to persuade parents to, when addressing vaccine hesitancy, let's say. It's not just vaccine is good for your health, it's also vaccine is good for your child's school attainment, and I think that might persuade some parents.
Yeah, that would be fascinating. We don't have vaccination data in eChild at the moment, and I'm not sure whether or how it would be possible to link that in. I think the community services dataset should contain information on vaccinations, but it's sort of patchy and missing, and I don't think there would be enough there, unfortunately, to answer that question.
Hi, thank you. My question to any panelist, really. We've seen that even with the most impactful public health research can struggle to reach the communities it's meant to help. Currently with this digital space and where most people get their information, I just wanted your thoughts on how important you think is digital communication in translating research and science, especially for those in early careers, without sacrificing the integrity of science. Thank you.
I can start. I'm sure others have comments. That's a fascinating question. We've done a lot of work with families where there's been abuse and neglect, so really very high-risk families. And interestingly, we've found that the digital space is a really great way to communicate. We've been trying to build an expert by experience recruitment team for trials, and actually we cycled around Glasgow with leaflets, and that made no difference. Once we actually advertised on social media, it was really helpful. And we've also tried, we'll find out in the next week whether it's helpful, but we've turned the results of a trial into an animation, and we're going to see how we can get that out on TikTok and Instagram and things. So I think it's a really interesting question, and I think there's lots of potential in that area.
Yes, completely agree. Yeah, really important to, I think, work together with community members and with experts by experience to understand how to enhance communication, either using digital means or any other means to reach families and to reach policymakers. So we've found that co-production has been a great way of working together with members of community to communicate fundings and to make them not only to make them meaningful to the community, but for us to understand the needs of the community, which I think is also very important.
Great. We'll have one more question from the room, then we can maybe go to Slido. Yes, there.
Yeah, hi there. I work for a knife crime charity in N17, and one of the big issues that the charity works with is the issue of school exclusions, which has a quite dramatic impact on young children's lives. And so we work with people who are considered to be likely excluded by the heads and the teachers and the parents. And it takes about a year to help address all the problems that have been picked up in the research as you've been doing. It takes quite a long time to change their behaviour from being at risk of causing harm to being, part of society. And I was thinking about the research you've been doing, have you looked at the impact of this, because of the high level of school exclusions in England, because Scotland sort of abolished it, but 61% of the male prisoners in the UK have been excluded from school. And so there's this interesting link. It's sort of things starting out in childhood with disturbed home life and eating and the rest of it can have an impact, but it takes quite an effort to change that. So I was wondering if anybody's got any links to data on, changing young people's attitudes through development programs and in mentoring and so on.
Yeah, school exclusions, not so much the interventions, but within each child we do have data on exclusions, and also off-rolling, where schools encourage families to leave a particular school. And Matt J, who's here, has done quite a bit of work in that area, looking at how particular groups of children are disproportionately affected by this. So children who are supported through statutory services, children's social care or special educational needs groups are much more likely to be excluded and to be off-rolled than others. So yeah, I think there's a lot of work to be done in that area, and also, as you're saying, to think about then what are the long-term outcomes of those trajectories. There are data that links MPD with criminal justice data, data first, the MOJ data. I'm not sure if they're doing anything specifically looking at that, but there's a lot of potential, I think.
I think, just to add to that, one of the things that we've been very concerned about is the underdiagnosis of neurodevelopmental conditions, particularly in marginalised groups. And I just would really urge us to think about that if a child is at risk of exclusion. We did a study recently in a young offenders institute, and there was just huge undiagnosed psychopathology and neurodivergence, and I think these are the families where often the parents are kind of poo-pooed. They're saying there's a problem with my child and no one's listening. They're thinking the problem is in the parents. I think we must be much more open to really listening to parents and understanding what might be going on.
Francis, can we just have the question from Slide if there are any, and then we'll move back to the... So, an online question. We've seen some great research presented here this morning. What one intervention or policy change would you most like to see implemented to improve child health? And I think you can all answer that.
Yeah. Let's go. That is a really difficult question and a challenging one to go with first.
Give it to someone else.
No, that's fine. I'll give it a go. I think there are a lot of policies and a lot of things on my wish list. I think I'm going to stick with the theme of my talk, and I think if we could make healthy, nutritious food more affordable and more accessible for families and children, I think that would greatly improve both their physical and mental health enormously.
That's a great point. I would focus all of our services on the most marginalised families and stop opening the doors to people who have the resources to go to their MSPs and demand it.
I think there are a couple of things. I think it all comes down to income and poverty, and if we're able to address that as early as possible, even in the data that we see, even before families choose to become pregnant and have children, addressing that sort of downstream is critical. And something we've not talked about today, but it's going to be increasingly important, obviously, is climate change and the effects that that's going to have on the health of our children growing up.
I think for me, within this review would be to simplify information, make it more accessible for families so that people understand eligibility criteria of services and can access the services that they deserve.
Okay, so we have another question from the room. Oh, yeah, got a question there.
Thank you. Hello, my name's Abiola Okubanja, and I'm a health social entrepreneur. So I think two of the panel talked about something that's really interesting to me. One of them talked about doing research with ethnic minority communities, and I think Helen, you also talked about working with marginalised communities. So two questions. With the ethnic minority research that you did, when we talk about ethnic minorities, it's quite all-encompassing, but obviously ethnic minorities are all very different. So sometimes that's a little bit frustrating for us, because I think when you especially when you link ethnic minorities, disadvantaged children, it kind of sometimes sends a strange message. So one of the questions I think I would ask is, did you see any differences between ethnic minority groups? That is worth highlighting. And then the other question that I was going to ask about marginalised group, we represent lots of communities who underrepresented or marginalised for various reasons. How could we get involved with more of your research so that we could actually have findings that are relevant to us, and that we could actually get involved at the co-design at the beginning, to actually co-design some of the questions that you're asking and the direction of your research, so that it's actually relevant to the communities that you're doing it for? Those are my questions.
So for your second question, I would point you to the co-production collective in UCL, because I think that's a great resource that link communities with academics. And I think as academics, we're always looking for getting members of the community involved in our research, so that we understand what the experiences or the needs are, and that our design really is based on those lived experiences. And we work together with members of the communities as experts in those lived experiences. For your first question, yes, I agree. This was a difficult choice to make within the review, because we started in conversation with the Welsh government, and their commission was on the Black ethnic and Asian minority. That's where they wanted us to do the research. But I mentioned we had 3 different research questions. Our first one was what evidence exists, and there was very little evidence, and that's the reason why we had to open to other groups which we felt were not getting access to the early childhood education and care. And in conversation with our lived experts from the Welsh government, we decided that we should open this to other groups, with the caveat that then it was going to be very difficult to disaggregate the data. So we ended up looking at many different groups, for example, traveller communities in the UK and Europe, indigenous communities in Canada, for example, Black ethnic minorities in the UK and Asian communities in the UK. And because of the nature of the data, of the qualitative research, it is difficult to sort of highlight experiences. But I would say that what's something that came up with in the data was these trusting relationships and the lack of representation from the staff in the early childhood education centers that was most relevant for the ethnic minority communities.
That's great, thank you. I think we've got time for 2 short questions. So we're not I think there's at least one question at the back. Oh, the slide, please. Sorry, I've totally ignored control. Sorry, I'll pass it.
Thank you very much. Okay, so I am the black sheep in this room, right? I am not a health person. I am an engineer. I'm from UCL Department of Civil, Environmental and Geomatic Engineering, and I have been working on the housing-related, determinants of health. I have done some work in the UK and, in fact, in the Canadian Arctic with the indigenous communities as well. So,
Your talk, Katie, was very interesting to me, and wanted to ask again, super, uninformed, I'm terribly sorry. I wonder if there is a standard list of things that in these visits that you mentioned, the people actually look into, and if any visible mold, damp, or condensation or moisture problems, damage in the fabric in the homes that these people go and visit the families with the newborns, is a part of the common practice, or can it be? Because, in the wake of the AWAP's law, it would be, I think, terribly to the point to actually start a practice where we can identify these housing issues early on, so that we can actually target those families for better housing conditions. Just wondered your ideas on that. Thank you.
Yeah, I'm going to hand that question over to two people who I think would be better to answer that. Firstly, Helen, who can maybe talk about the role of health visitors in identifying household problems, and then Pia, who's working on the Kids Environment and Health cohort, which is looking at various things, including housing quality and impacts on child health. Helen's just there, and yeah.
Thanks for your question. So, yeah, very much part of the role of the health visitor to identify these issues. And as a health visitor, albeit 3 decades ago, I spent a lot of my time reporting such issues to the housing departments. But, we all know how difficult it is. It was difficult then. It's probably even more difficult now. But yes, absolutely. I mean, health visitors are on top of this. This is part of their bread and butter work.
And in terms of data, I don't think it's part of the community services data set in England, but we do have that data for Scotland, actually, and Caroline, who's sitting at the top there, maybe you can wave. She's doing work on housing and respiratory infections in Scotland, so she can chat to you. Right, have we got one more time? Really quick slider question, what do you think? Really quick. Yeah, okay. So I feel like thanks.
Okay, last question from our online audience. Is there evidence on how early the health visiting service can be most effective, such as antenatal versus postnatal visits?
If I have to give a very short answer, I'd say no, because of how difficult it is to evaluate these services, because they're universal. If you're trying to work out, okay, does more health visiting in the antenatal period as opposed to later period affect outcomes, we don't have the information that we would need to adjust for the factors that mean that the families who are most at need will get more contact. So you will always have this problem where you can't measure the underlying need well enough to be able to account for that in a sort of quasi-experimental way.
And just a comment which is slightly anecdotal and also evidence-based. There's a big trial called Thrive, which looked at antenatal support, not specifically through health visiting, partly through health visiting, and there wasn't a difference between the groups. And I think what I was part of one of the co-investigators, we suspect that there's something about actually having your baby in your arms that kind of plugs you in a way. So I'm always just a little bit more focused on immediate postnatal. But you're absolutely right, it's very difficult unless you can compare countries, and then it's ecological. I mean, you look at the States, and I think that a good bit of information is that the family nurse partnership was much more effective in the States than it was here. But of course we have health visiting services, really quite good, very good health visiting services here. So I think that's a good way to maybe end and just remember that we do have amazing health visiting services.
Thank you so much. I'm going to close this session now, but for everyone who I totally ignored, you had your hand up, please do find the speakers at lunch. Thank you so much again to all the wonderful speakers. It's been for listening as well. Thank you so much.
Yes, thanks, Pia, for chairing and for the great presentations and also the great questions both online and from the audience. Please do keep it up. We're online on Blue Sky and X, so please give us your thoughts and any feedback. It's now time for lunch. You, during this hour, have also have the opportunity to look at the posters in the downstairs in the Winter Garden. Please look at those. They're really superb, and the best of them is going to receive a prize later this afternoon. So we've got an hour for lunch, well, just less now. So we'll see you back here at 1:20. But thank you very much.